Yeah. So, is the screen visible to you, Smita?
Can you hear me?
Yeah, I can hear you. Are you able to see the case?
No, just 1 second. Oh yeah, I can see it now.
Sure, sure. Okay. Yeah, you can start.
Okay. Provided to me is a anterior-posterior view of the foot, X-ray of the foot. Um, I'm trying to see if there is any abnormality that is striking to me. Yes, so I can see that there are subarticular erosions noted on the first metatarsal. Also, they are present in the proximal phalanx of the big toe. And there is associated soft tissue opacities adjacent to the metatarsophalangeal and the interphalangeal joint. I'm trying to see if there are overhanging edges or uh, rat bite type of erosions in this case, because it is involving the first metatarsophalangeal joints. Um, I can see that there is sclerosis around these erosions, saying that it could be a chronic process, slow chronic process. The zone of transition is narrow, so this is a non-aggressive type of erosion. Looking at the other joints, rest of the metacarpophalangeal joints and interphalangeal joints are relatively normal. The midfoot and the hindfoot in this view appears normal. So, in my routine practice, I would like to correlate with the previous films if they are present. Also, I would like to see the contralateral foot, the left foot of the same patient, and any orthogonal views if present. But on this film, my provisional diagnosis would be a gouty arthritis. Um, to confirm, I would like to ask for the history and clinical profile of the patient. And I would refer this patient to the orthopedic team and suggest for serum uric acid levels. If they're raised, this would probably a gouty arthritis. Thank you.
If I tell you that my concern is that there is a soft tissue hyper radiopacity, and I think it's calcium versus gout. So what kind of crystals do you see in gout?
Sodium urate crystals.
Okay.
Uh,
So how do you differentiate between monosodium urate crystals and calcium? What investigation can I do to differentiate between them?
the gout crystals would not show bifringence. Um, However, the other ones would show a bifringence. Also, there is difference in the shape. I think these are the gouty arthritis crystals are hexagonal, polygonal in shape, and um, uh, uh, the other ones are a needle like in shape. However, I'm not very sure of the later point.
Okay. No, I'm asking, is there any imaging technique that can help me differentiate between monosodium urate crystals and calcium?
We could do a DECT. Um, DECT would be able to.
Could you expand it for me?
Um, with DECT, we could image it with
No, no.
two
Could you
kidneys.
expand DCT for me?
I'm sorry, dual energy computed tomography would be able to differentiate in between two, where the classical appearance is green color crystals in the metatarsophalangeal region.
What would be the treatment?
The treatment would be decreasing the uric acid levels by medications.
Okay.
Um,
What medications are you aware about any medications?
I'm forgetting the name.
Okay, no problem. Can you tell me what could be give me few conditions that can predispose to um, gout? Any conditions? Few
Uh,
conditions.
so it could be a primary metabolic abnormality where the uric acid mechanism itself is at fault,
Okay.
or it could be secondary where the body is producing excessive uric acid,
Acid.
um,
Acid.
as in cases of excessive um, excessive uric acid consumption, such as in bodybuilders, they ingest a lot of creatine supplements. That could be a case. Also, um, um, heavy a lot of red meat within the diet could also increase the uric acid levels.
Okay, thank you. So we'll go to the next case. This is your next case.
Okay.
Yeah, you can go ahead.
So this is a ultrasound image done with the curvilinear probe. Um, I think this is a antenatal ultrasound of a fetus because I can see a placenta in the along the anterior wall with some fluid, amniotic fluid around it. Um, okay, the fetus is at the left side, and the torso of the fetus is on the lower part, I think. Yeah. So I can see a fluid, an anechoic area with some echoes noted within, possibly near the renal fossa or in the region of the stomach. I am not very sure because these are not a dynamic set of images. So other than that, I can see the diaphragm very clearly on these set of images.
Can you ask for control and show it to me?
Right. So I have requested control.
Yeah. Okay. Go ahead.
So I think this is the diaphragm. Can you
Oh,
see my
yeah, I can. Yeah, that okay, okay. So what do you think?
and
What do you think that structure is then? The below it.
so it could be the kidney with the hydronephrotic pelvis.
Do you think?
It could
Do you think any other structure can come between kidney and diaphragm at that level?
it could also be adrenals, so in the suprarenal region, with this being an adrenal hematoma in this scan.
Okay.
This does not look like a stomach because it is very rounded in shape. A distended gallbladder could also appear, which I'm in my routine practice, I would see the situs of this patient and see where the liver is.
Anything
So,
else abnormal? Anything else abnormal in the screen? I mean, the image that you're being shown.
okay. I am not able to see the.
What do you think this? Sorry, what do you think this structure is?
Okay. That looks like the aorta
Uh,
or the major vessels.
can you trace that structure? Where does it end?
It ends. Okay. It is ending just at the level of the diaphragm, and then there is a branch probably going within this area.
Into this area?
Yeah.
Yeah. So
Yes.
what do you think if
So
it's a continuous structure? What could you think of?
so
Along
this
with
could
that,
be a renal artery just supplying the pelvis, or okay, this could be aneurysmal dilatation of the branch.
mhm.
Um,
Okay. What would you like to do next?
I would like to see the dynamic set of images in my routine practice and correlate on the other
Unfortunately,
views.
we have only one more image, so this is the image.
Okay. Okay. These are so these are um I think this I'm not able to make out which part of the body it is. I'm just trying to see for any I think this is the abdomen.
Yeah, yeah. So what do you think this structure is?
Okay.
What do you think
So
this?
these are calcifications which are giving a lot of posterior acoustic shadowing
Okay,
in the posterior part of the abdomen with likely bowel loops anterior to it.
okay.
So um,
So what do you think? Uh, since you've been just given a static image, can you interpret anything from the bowel that has been shown to you?
so so multiple dilated bowel loops could be with such a calcific area. Um, it could be a neoplastic etiology within the abdomen, which might be causing an obstruction like a neuroblastoma. But
What if I tell you this patient has does not pass, has problem with passing stools,
Okay.
and
In
he
that case,
did a lower GI study and there was microcolon as well. Does that help?
okay. So the microcolon would explain the dilated bowel loops.
Last 5 minutes.
And these calcific structures could be lymph nodes or segmental vertebral anomalies.
Okay. What would you like to do next?
If the patient is already delivered, I would like to reassess the X-ray images of that patient to see what the abnormality is, because the patient is not passing meconium. And I would also like to image um, the abdominal sections with cross-sectional imaging such as MRI for further characterization. Thank you.
This is your next case.
Okay. This is a frontal radiograph of the upper sections of the abdomen of a skeletally mature patient. I can see that there is a lucency, irregular air lucency noted within the hypogastric region. There is another rounded lucency noted in the left hypochondriac region.
You can ignore that. You can ignore that.
So
You can ignore
okay.
that. Yeah.
So other than that, the visualized bones appear normal. The liver and the splenic shadows are unremarkable. The lung sections and the visualized diaphragms and the cardiac shadows are unremarkable. There is no regular sign noted within these sections. So I am thinking in terms of some motile air-like lucencies. It could be a case of emphysematous pancreatitis, or I'm also thinking it can be retroperitoneal air in case of perforated duodenal ulcers or gastric ulcers, or it could be just retroperitoneal air.
This patient
So
had a recent renal procedure done, and now the patient complains of hematuria.
okay. So in a case of renal intervention, which was recent, this could be emphysematous pyelonephritis with retroperitoneal air,
Anything else that you have
pneumoretroperitoneal.
seen? Anything else that you think you might have missed?
Okay.
Can you look at the corners of the screen of the film?
Okay. The patient is supine in position.
Okay.
So
No,
so
I mean
this
there is something that I want you to pick up.
okay.
There's something else that you've not picked up yet.
Um There's some soft tissue noted in the right lower side of the film. This could be
Ignore that. You can ignore that.
okay.
What is
I'm
the
looking
first thing? What is the first thing that you look when you get a chest X-ray and abdomen? What have you like? What do you look? What do you say first?
uh pneumoperitoneum.
Anything else?
So
Anything else?
um other than that, the
If I tell you that patient had a recent procedure, what would you be looking in the radiograph?
uh any abnormal air within the visualized sections, or any stent which is probably
Exactly.
misplaced.
Exactly. Now, can you pick up anything abnormal in this radiograph?
I can see a linear radiopacity also at the edge of the film, on the lower edge of the film,
Okay.
just in the paravertebral region.
What would you like to do next?
I would like to advise a CT scan for this patient, a contrast CT scan for this patient to look at if this is a renal procedure, this could be a misplaced stent.
Would you
Uh,
would you would you directly go for a CT, or would you ask for an entire pelvic radiograph?
yeah, I would go with the pelvic radiograph first, followed by a CT scan if necessary.
Yeah. So this is your radiograph.
Okay. So I can see that there is a stent which is noted, which is I'm
Time up, guys.
Okay.
okay.
Yeah. Thank you. I think we'll continue with Dave, and then last I'll give you the feedback about this. Okay. So I'm going to
Sure. Okay.
ready. Yep.
Oh, just give me one moment. Okay. All right, I'll just share my screen quickly. Nikhil, you need to allow me to share screen again.
Sure. Yeah. One second. Yeah, please.
It's done?
Yeah.
Yeah, okay, cool. It should be visible. Is my screen visible to you?
Dr. Smita?
Yeah, I'm able to see.
Great. Yeah.
You're able to see, right? Okay, just give me one moment. Okay. So yeah, Nikhil, can you start the timer?
Yeah, sure.
Okay.
I can see only the upper part of the humerus. Is that the
Yes.
okay. Okay.
You should be able to see the humerus, the proximal humerus.
Yeah, I'm seeing that. Correct.
Okay, you can start.
Okay, so provided to me is the frontal radiograph of the shoulder region of a skeletally mature patient. I can see that there is
Sorry, I'm so sorry. It's probably yeah. Go ahead.
yeah. I can see that there is a lytic area noted in the greater tuberosity of the humerus, with the rest of the humerus showing increased trabeculations and some cortical thickening as well, especially in the diaphyseal region. Uh, it is quite well defined with the narrow zone of transition. There's no associated soft tissue calcifications or any breach in the cortex in the visualized sections. The visualized portions of the scapula and the distal end of the clavicle appears normal. The acromion and the coracoid process acromioclavicular joint is relatively unremarkable. However, I can see that the lower portions of the acromion and the clavicular are not aligned with each other. I would like to correlate it.
You can ignore that. You can ignore that.
Okay. The rest of the lungs appear unremarkable. Also, the ribs are normal. So, in this patient with a well-defined lytic area in the humerus with cortical thickening and increased trabeculations, I would like to correlate with the age of the patient. If it is more than 50 years old, I would be thinking it could be a case of Paget's disease. Other than that, just regarding this lytic area, it could be a chondroblastoma in the area of the physis of the greater tuberosity of the humerus.
Do you see anything suggestive of chondroblastoma here?
Just an area of lysis in the area of the greater tuberosity, a well-defined area.
And what do you expect? What else do you expect to see in a chondroblastoma?
It should be well-defined and a sclerotic margin in either in the epiphysis or an ossification center. But yeah.
Okay, apart from, but so which is your most likely differential of the ones that you mentioned?
I think it could be a case of Paget's disease.
Okay. Is there anything else you would like to do?
I would like to correlate with the previous films of this patient and history of this patient, and also scan for any other joints for any other involvement. And I would also suggest a nuclear bone MDP scan to look for any active areas. suggesting Paget's disease. And I
Okay.
would like to also suggest this patient, discuss this patient in the orthopedic MDT.
Okay, we'll go to the next one. So I'll quickly show you 4 images, and then you can tell me which ones you want to see. Okay, this is the first image.
Okay.
Let me know when you want me to switch, because you can't scroll, so that's why I'm just gonna show you quickly.
Okay. Right. Okay. Okay. And right.
So elderly female presenting with abdominal swelling.
Okay. So, these are images of the ultrasound done with a curvilinear probe in a elderly patient with abdominal pain. These are soft tissue. There are 2 soft tissue well-defined lobulated areas which are hypoechoic, um, probably noted in the pelvis.
They are in
Uh,
the pelvis, yes.
Right. So they're marked as right O and left O. I'm thinking that these could be ovaries. So, and also in the later images, I saw there was ascites with adjacent fluid with echoes and some irregular areas of probably fat stranding and some also lobulations which were irregular. These could be deposits. So in my routine practice, I would also put some color Doppler on on these uh, these masses and see for any if they take up any color flow.
Mhm.
In an elderly female, I would like to raise a high suspicion of ovarian malignancies with deposits within the abdomen. Also, secondary differential could be these could be Krukenberg tumors of the ovaries with a possible malignancy in the abdomen, and other differential could be metastasis of the ovaries. Yeah, Krukenberg metastasis of the ovaries. And I would like to ask for the history of the patient about how the course of this disease was. And
So when you're asking
ask
for a
for,
history, what are you really looking for?
um, if because these could also could be tubo-ovarian masses of tuberculosis or any infective etiology. If the patient has any fever, it could also be
No,
that.
the patient does not. But the
Okay.
patient is known to the hospital.
Okay. So, and then
So
these.
when you said deposits and metastasis, what kind of primaries are you thinking about?
So I'm thinking about gastric malignancies or appendicular mucinous CAs or any bowel carcinomas that can drop metastasis in the abdomen and pelvis.
Which do you think is the most common among the ones that you mentioned?
The bowel CA.
Bowel CA. Okay. Anything else, especially in an elderly woman, that you'd be concerned about?
Breast malignancies.
Mm-hmm. Okay. So we'll move on to the next one.
Okay.
So this
Um,
patient presented with dysphagia.
okay. So this is a frontal radiograph of a barium swallow study showing the upper and the mid part of the esophagus. I can see that there is a esophageal stent noted within the lower part of the esophagus with some clips suggesting that this could be a post-operative scan. Just above that, I can see an area of abrupt cutoff with luminal narrowing. Um, the proximal esophagus appears mildly dilated. I do not see any ulcers or mucosal irregularities or filling defects above it. So, so this could be a case of a CA esophagus that they have stented because it is a locally advanced disease. Or this could be a post-operative case of anastomosis with stenting being done. I would like to review the history and clinical file of this patient to see what kind of surgery has been done.
Uh,
And
You're right. It is a case of esophageal carcinoma. But before you ask about the surgery, can you tell me what else are you looking at the image? What do you think is happening?
So, just proximal to the stent, there is an area of luminal narrowing. So it could be an area of recurrence or a spread.
Area of recurrence or spread above the stent. Okay. Anything else comes to mind? Any other possibility?
Um, in the lower part of the image, I can see that the stent is opening into the stomach. That appears normal.
Okay. So if I were to tell you that, let's say, imagine that this is they placed a stent and they wanted to see the location of the stent, and then this imaging was done, would you say this is a correctly positioned stent?
Um, no, because there is an area of stricturous abnormality still noted, so they need to pull it a little bit up than it is right now.
Okay. Okay. So could this be a complication of a procedure? Can you think of something along those lines?
Okay. Right. It could be a displaced stent. Other than that, it could be if this is a gastric pull-through operation with
It's
stent.
no, no, don't go there. It's not a gastric pull-through operation. That's okay. We'll move on to the next case. Okay.
Yeah.
So you ask for control and I'll give it to you.
Okay.
Go ahead. You have control.
Okay. These are actual T2 weighted images of the brain. I'm just scrolling from cranial to caudal direction to see for any obvious abnormality.
Just
The
letting you know that you have 5 more minutes left.
Okay, the ventricular system appears normal. I'm trying to see for any abnormality. Okay, you can see that the right optic nerve appears smaller in diameter than the left one with a dilated,
You can ignore that.
okay. Other than that, I'm trying to see for the white matter and the gray matter to see any abnormality. There are lacunar infarcts in the corona radiata, chronic lacunar infarcts. Looking at the venous sinuses and the vessels in the base of the skull. Okay, they appear normal. There is mild right maxillary sinusitis. The medulla, there is abnormal T2 hypointensity noted in the anterior part of the medulla oblongata. So I'm suspicious if this is artifactual or this is really there. So I would correlate with the GRE sequence to look for any hemosiderin staining in that area.
Unfortunately, we don't have a GRE sequence for this patient.
Okay. There is some abnormal hyperintense signal noted in the medial temporal lobe.
You can ignore that. That's not a concern here.
Okay.
In your routine practice, what do you do when you see this kind of a case?
I would correlate with the flare sequence and
If you just let go of the mouse for one moment, I'll give you the flare sequence and you can take a look. Go ahead. You have control again.
Okay, I can see that there is T2 flare hyperintense intensity in the medial thalamic region. I'm trying to look for any other T2 flare hyperintense signal. There is also some signal noted within the medulla in the central portion. So, in this, I would like to correlate with the history of the patient. If the patient has a history of chronic alcohol consumption, this could be a case of wernicke's encephalopathy. Other than that, if there is a sudden deterioration in the neurological status, I would also keep a differential of Creutzfeldt-Jakob CJD, Creutzfeldt-Jakob disease.
The patient is an elderly patient, had previous GI surgery and has nutrition, but no, he does not have any acute symptoms at present.
Okay, so because of nutrition also, there could be chronic vitamin B deficiency causing this appearance of wernicke's encephalopathy. I'm sorry, vitamin A causing wernicke's encephalopathy. And
Are you
uh,
sure about vitamin A?
um,
What nutritional deficiency causes this?
uh, chronic,
Yeah, I was just, I'm sorry, this is coming up here, but yeah, we'll,
uh,
yeah, if you're saying,
yeah, chronic thiamine deficiency.
okay, we'll move on to the next one. What do you think?
So this is a frontal chest radiograph of a skeletally mature patient. I can see that there is a radiopacity noted in the lower zone of the lung, um, which is which has loss of silhouetting with the diaphragm, also right heart of the border. There is a increase in the right paratracheal soft tissue as well, with reticular nodular opacities in the rest of the upper and middle zones of the lung parenchyma. Um, so I'm looking for any for the left lung that appears normal. There is tracheal shift towards the right, inferring that there is some volume loss also within this area. So this could be with these reticular nodular opacities. These could be um, uh, okay. So this could be a large mass noted in the right lower zone with a lymphangitic carcinomatosis with involvement of the mediastinum as well. Other differentials could be
Your
uh,
time's up.
rotational.
Time's up, yeah. Time's up,
Yeah.
yeah.
So, okay, no problem. So Nikhil, you do you want me to discuss the cases first, or do you want to go? Then so we'll move back to the first case. Okay, so this one was well done. You identified the pathology quickly. I just have two comments to make here. Number one, when you have identified the pathology, immediately, and you have quickly looked at the other areas and you haven't found anything very important, you can shorten that bit of your presentation. You can just say the lungs, the bones, the soft tissues, and the visualized part of the abdomen looks normal, and finish it in 10 seconds instead of. So give yourself more time, because this is one of those typical opening cases. You hit it for a 6, finish it in 30 seconds to 1 minute, and move on. Give yourself more time for the inevitably hard cases that come next when you're sure. The second comment I want to make is you were pretty confident this was Paget's, right?
Yeah.
Then don't bring the extra differentials, which are very less likely. This does not look like a chondroblastoma. You would expect the convoid pattern of calcification. If it's very aggressive, you'd expect cortical breach, soft tissue masses. Again, I know, sorry, not soft tissue masses, but you don't expect the coarse trabecular, right? That you typically see in a Paget's disease. So you knew it. That's why I knew you were confident, but just don't add it just because you have to. You could say there are other possibilities, but they're very unlikely. Okay, just save yourself some time. Second one, again, sorry, yeah, this was very well done. This is a case of Krukenberg's tumor. I would have liked it a bit more if you had just considered the possibility that it could be primary bilateral. You did say it, just didn't use those words. Otherwise, again, this is very well done. I would give you a 7 for this as well. You described it well. You mentioned what you do in your usual, work cases as well. Yeah, so this is a case where this is a case of esophageal stent migration, which you got there eventually, but you needed help. But you did explore the possibility that it could be a recurrence above the stent. It's not impossible. It can happen. Other than that, yeah, you described this one well. There's not much going on here, except for the fact that I just wanted to keep a case of stent migration. We don't see this very common, but it is something that can turn up in the exam. This one, yeah, I specifically kept this case because and this goes for anyone who's listening. These days I prefer that when you're talking about these cases, call it thiamine deficiency. That's the diagnosis, and not Wernicke's, because you can then. Nikhil, can you hear me? Um, I think there's something going on with Nikhil. I'll just be on a call with him. But anyway, so yeah, just use the more general term like thiamine deficiency, because as I said, this case was because of nutritional deficiency secondary to a GI surgery or whatever else. They look the same because it's ultimately thiamine. And when you're not sure about which vitamin, don't even get into that area, right? Vitamin A, B, you're just creating more because in this case I've given you a 6. You've already passed in this case. Just don't make sure you don't make more mistakes about this. Okay. And it would have been better if you'd asked for the diffusion as well. You could just say in my routine practice, I see all the sequences and I want to see if there's any restriction, which other helps your diagnosis. Finally, did we go to this one? Yeah. Yes, it can be a case of lymphangitis carcinomatosis, but if you had more time, I guess we could have explored the fact that with a completely left normal lung and this kind of a lung, you have to consider the possibility that it can be a case of transplanted lung on the left. Because if I were to show you the previous image of this patient, this was how their lungs looked. So this is a case of chronic ILD, and this patient had a left-sided transplant. And if you see I mean, you could say that I'm looking for evidence of any surgery like hilar clips, which is not visible on the radiograph. But if you were to move to the CT, you would have found evidence of these little clips here, which are, confirm the fact that there has been a transplant on this side. Okay, so Nikhil, can you hear me now?
Yeah, I think it was a glitch on my side.
You can hear me, right? So, yeah,
yeah,
okay. So I'll stop sharing.
Yeah.
Yeah, okay.
I think, Smita, regarding Dave's cases, I think I don't have much to add. I think your approach was good, and you picked up the findings quickly, except for a few areas. But then I think just be very careful about what you say, especially the vitamin deficiencies. Those are very
Yeah.
simple things that you shouldn't mess up. But otherwise, you're fine. Okay. So I'll just quickly go to cases. You should always look at the corners of the right. Whenever they give you.
Still, your voice is a little cracking. I'm not sure if it is
Nikhil, you're having audio issues. Your voice is chopped up. We're not hearing you well.
Yeah, am I audible now?
Yes.
Yeah, you are.
So when you're given a case like this, and when I give you a history that there is a previous renal procedure done, always look at the corners of the film to see if there is any implant or any stent. In this case, I do think that it's quite difficult, but then always when you look at the corners here, you can see an implant projecting, right? So in such cases, before going in for cross-sectional, always ask that I would go for a complete radiograph of the pelvis. And if you look here, and I already gave you a history that this patient had a history of hematuria. So what has happened, the stent has passed beyond the level of the urinary bladder and gone into the urethra. So a possible urethra injury has caused it to result in hematuria. Okay. So oftentimes you might not get a very tough case. It would be a very straightforward case. So all it needs is a bit of understanding what should you be looking for. So when I tell you renal procedure, if they tell you some renal procedure, always look for something like implants or lines and tubes. Okay. This case, this you picked up the findings, and then when I gave you an idea, when I gave you information, I thought you might say this could be stomach and this is esophagus, right? If it's and you picked up this is diaphragm, and then I asked you, is there something between the kidney and the diaphragm? So one good possibility was stomach. So what has happened here is the stomach is distended and there is dilatation of the esophagus, right? And associated with that, I showed you this. The fact that there is the AFI is elevated 25, which means it's polyhydramnios. And then I told you there is microcolon. So, and I showed you specifically 3 bubbles, right? So this was a case of a jejunal atresia, which is, and this was vertebrae, but I think you got a bit carried away thinking that this could be a mass with calcification, but then it was a case of a jejunal atresia. Now I hope the picture fits, right? So there is polyhydramnios, there is triple bubble, and also there is dilated esophagus, right? So that was this case, and this case you did well. Your approach was good. You picked up all the findings. You gave me all the positive findings with respect to the case. Regarding the questions that I asked you subsequently, I think please always ensure that you expand whatever you're saying, because sometimes examiners will not be able to understand what DCT is. Okay. Second thing, always remember one or two things about the treatment. Like in this case, it's allopurinol, the treatment of choice, which is a xanthine oxidase inhibitor. At least know till that level. I don't. We don't. They don't expect you to know a lot of medical stuff, but at least the basic drugs, and also the predisposing condition. Whatever cases you're getting, learn at least 5 to 6 predisposing conditions with respect to that. Okay. So I think I showed you these three cases. Dave, do you want to add anything? Dave, are you there?
Yeah. No, I think you covered everything. Yeah, I mean, I had generic comments which were the same. I mean, your approach is good. You have a good speed going on. Just need to, I guess, work on these little things like looking at the corners of the film and asking for other sequences the things that you do in your routine practice. Just be more upfront about asking about them. And yeah, corners. Yeah, can't stress that enough. Yeah.
Yeah. Okay. Thank you, Dr. Smitha, for participating with us.
Yeah, could I just ask
Sure.
two doubts?
Yeah.
Yeah.
In the barium swallow case, we said that it could be migration. So what would be the normal region that would this stent be in?
Oh, you're not supposed to see the mass lesion above the stent, right? The stent is
Okay.
there so that there is no obstruction. That's the purpose of the stent. So making sure that the stenosis created by the mass lesion is being treated by the stent. So if there is the mass above it, it's not serving its purpose. So one possibility is there that the mass has recurred superior to where the stent was placed. But in these cases, you always look at the previous imaging and you find where the stent was and you know that it has migrated.
Okay. And
Also,
the
the time frame will help you. If this has happened within weeks, days to weeks, then you don't expect it to be a recurrence, right? Whereas if this depends on what kind of time frame you're looking at.
Right. And thank you so much. And in the stent migrated DJ stent case, I saw some motile lucency in the epigastric areas that was not there, or was it a concomitant abnormality?
Nikhil, I think that's your case. She's asking about the renal stent case.
Yeah,
Yeah.
the first
Yeah, the
radiograph.
renal stent. Yeah, the renal stent case, there was nothing else apart from the stent. There was no other
Okay.
abnormalities. Yeah.
Okay.
Yeah. Okay. Thank you so much.
Thank
So,
you.
yeah, thank you. So if candidate B is ready, I think we can go ahead with the
Okay,
first
yeah, we can.
case. Yeah. So, shall we start, candidate B?
Yes.
Yeah. Okay. Cool. I think we have a question from Dr. Priya. In Paget's, was there a light lesion, Dave?
I'll answer that. You can go ahead. Yeah.
Sure. Okay. So this is your first case, candidate B. You can start.
Provided frontal projection radiograph of pelvis in a skeletally immature patient. I can see a bony avulsion involving the anterior inferior iliac spine on the right side. It is possibly avulsion of the muscular tendons attachment. At this region, I will expect not sartorius. Yeah, I'm not able to recall right now. Other than that, I'm looking through the rest of the visualized bones. I can't. The rest of the bones appear symmetrical. Uh, the surrounding soft tissue and the lower lumbar spine and the sacroiliac joint, everything is normal. So I will inform this finding to the referring clinician. We'll discuss the case in the orthopedic MDT. Yeah, thank you so much. And I would also compare if any previous images if available.
So the orthopedician or the physician is asking you like which muscle is involved. What would you think of? Shabib, Dr. Shabib?
Rectus femoris.
Okay, okay, great. So this is your next case.
provided frontal projection radiograph of selected images from the possibly micturating cystourethrogram. Would I can see that the bladder is distended, and I can see some outpouching from the superior dome of the bladder. Project that's possibly the penis. Okay. Other than that, I can see there is reflex of the contrast material, which is extending along the left bilateral ureter. On the left side, it's more clearly seen, which is extending up to the, yeah, it's okay. I think it's on the left side only. This is possibly the urethra. So left side reflex extending up to the renal pelvis. There is no dilatation of the calyx or blunting noted. I can also see there is increased density along the wall of the bowel loop, adjacent bowel loop along the possibly along the transverse colon. Not sure whether it is contrast leak or not. I would check all the images. Will compare with the non-contrast images to assess better that. Then other than that, trying to see rest of the film, rest of the bonds, visualize bonds, rest of the uh, bowel loops normal. Okay, so this is a case of vesiculated reflex, uh, grade 2 vesiculated reflex. I would compare with the plain images. I would, in my routine practice, I would check all the available phases of the same study. And
So you did not.
the other possibility would be yeah, I can see the barium labeled here. So this is possibly uh, renal excretion, but I don't think so, because all the bladder, everything is well opacified with the contrast. So other possibility would be uh, bowel perforation. I can see mutant lucency, the right upper quadrant. So a bowel perforation with contrast extravasation and a renal excretion. That would be another possibility. Other possibility would be this would be a smaller the reduced caliber bowel loop with yeah, reduced caliber bowel loop, which is extending from the pelvis into the left upper quadrant. In that case, this is possibly uh, a narrowed segment of the large bowel loop with upstream dilatation of the bowel loop. So it's possibly a bowel obstruction. So I would get more details from the patient history. If there is a abdominal distension, vomiting, that would be
Bowel
more
is completely fine. The bowels are completely fine.
Okay, okay.
So
So
what do you think? What is how you were describing something about this, right? What do you
yeah,
think? What are your differentials at this point? What are you thinking about?
this could be a urachus, persistent urachus. The other possibility would be a diverticular outpouching from the bladder, bladder dome. So
What would
most
you like
common,
to do next? What would you like to do next?
I would compare with the previous images if available. I would also correlate with ultrasound finding. It can better characterize this.
No, but we
Then,
have few other images for
yeah,
you to compare. You want to have a look
yeah,
at them?
the orthogonal view also. Yeah, thank you. So yeah, orthogonal projection shows uh, dilated. There is outpouching from the bladder, dome of the bladder. So the possibility could be a urethral obstruction, a posterior urethral valve obstructing the urethra and causing the obstruction, bladder outlet obstruction, and causing a bladder outlet diverticle. In that case, I would expect to see a reflex, vesiculated reflex on the either side. So yeah, and I can also see some. Uh, yeah, I'm trying to see the vertebra. Vertebra looks normal. I can't see any some widening I can see in the pre-cycle location. So I would compare if any MRI images to see is there any underlying spinal lesion also. Okay.
So
Yeah,
so what's the differential at this point?
so one possibility I'm considering is a bladder outlet obstruction due to a posterior urethral valve causing a bladder obstruction and our bladder diverticulum. Other possibility I'm considering is a urachal diverticulum. In that case, I would recommend a prawn images as well to see whether it is communicating with the umbilicus. And I
What,
would also correlate with the ultrasound finding. I
so
would
if you
inform
tell,
this finding to the referral clinician and discuss the case in the pediatric urology MTT for further management. Thank you.
so if you tell me that this is a diverticulum, what should I be worried about?
Yeah, there is a possibility of a secondary malignancy can arise from this. That is adenocarcinoma can arise from this. So needs I would recommend surgical excision.
Okay, okay. So this is your next no, wait. Yeah, this is your next case. It's a video case. You can see through the video and
Yeah, okay.
so this
Provided cine
patient,
images of
I'll just give you a quick history. This is a
yeah, sure.
30-year-old female who had previous three deliveries, which was cesarean. Now the patient has presented to your clinic. Yeah.
Okay. Provided cine images of 30-year-old female who had a previous three cesarean delivery, now presented to my clinic. I can see cine images, selected cine images using curvilinear probe ultrasound images. I can see that uterus is this. I can see uterus is bulky, enlarged, and I can see that there is a scar in the anterior lower section, lower anterior uterine wall. I can see a gestational sac overlying this location. Uh, I would, in my routine practice, I would uh, check the crown drum length of uh, the embryo fetal pole to confirm the period of amenorrhea and the gestational period. Yeah, I would also check with the Dopplers. Yeah, I can see that Doppler signals showing color uptake and possible cardiac activity. So this is an emergency. I would immediately take up my phone and inform the gynec on-call person regarding this. This is a scar ectopic pregnancy. I'm seeing the placenta, which is and yeah, anteriorly the developing placenta. I can also appreciate anteriorly. Okay, I'm trying to see is there any myometrium in the intervening portion or the I'm trying to see the cervical canal also. The other possibility would be a cervical pregnancy. It doesn't look like a cervical pregnancy. Other possibility will be a lower implantation of the gestational sac.
What? So your differential is a scar side pregnancy, is it?
Yes, car side pregnancy and other possibility will be low. I would
What
my routine
complication?
practice. I would say,
What
sorry,
complication are you anticipating?
the rupture and yeah, rupture of the uh,
What do you think is the treatment plan now?
uh, immediate termination of the pregnancy,
What kind of, so how would you terminate? How would you generally recommend?
laparoscopic.
Okay, okay. Do you know any specific treatment which we radiologically do for
We
Last 5 minutes.
we can do. I would. We can do a methotrexate injection also. And, yeah.
So this is your next case. You can ask for
Okay.
control and scroll. Yeah, you can scroll.
Okay. So provided selected images of DSA angiography. The left, yeah, possibly a renal angiography. I can see the contrast filling the renal artery and the renal parenchyma also getting pacified. And catheter tip is noted at yeah, the renal artery ostia. So I can see some wires, which is possibly the external wires. I'm trying to see through the scan. I'm trying to see is there any obvious abnormality. I can see that the renal arteries are pacifying normally and dividing into the superior and yeah, inferior division. Other than that, I'm trying to see is there any active contrast leak or a vascular outpouching or I can't see any caliber narrowing or a beaded appearance of the renal artery. Okay. I can see mm, there is the lower segment renal artery appears smaller in caliber, and there is also a difference in opacification between the upper and
You can
lower renal
you can
parenchyma.
ignore that. That is normal. You can ignore that.
Okay. Other than that, I can see some blush, contrast blush in the perirenal location in the interpolar region. I can also see some uh, hypodense structures. I would ask is the patient is undergone any recent surgery, sorry, recent procedure such as renal biopsy or a stenting. I can't see any stenting. So in
No,
that case,
patient came to the emergency clinic following a road traffic accident.
okay. In that case, it's concerned for a renal injury with an active contrast extravasation.
So do you
Uh,
see any abnormal
I can
areas?
see. Sorry.
Do you see any abnormal areas in DST?
Yeah, I've seen. No, like I've said, there are contrast extravasation along the perinephric location in the upper pole and interpolar region,
Okay.
and
So where is the source of that injury?
yeah, this possibly in the interpolar region only. Yeah, this is the perinephric location. Um, I
Okay.
can't. Actually, I'm not able to clearly appreciate the. Yeah, I think this is the area, the abnormal area. Uh,
What would you like to do next?
I would correlate with the CT findings if the patient has taken CT, or I would also check with an ultrasound if ultrasound was
I
done.
can give you the CT. I can give you the CT.
Yeah.
You can click and scroll.
Okay. So provided axial section, post contrast axial sections of abdomen and pelvis of the same patient. So I'm quickly coming to the area of interest. Yeah, I can see perinephric hematoma, which is pushing the kidneys and antro anterolaterally. I can see a contrast blush in the lower pole perinephric location. So this is a page kidney, perinephric hematoma
Would
with
you call a
mass effect
kidney
on the,
page
and
kidney?
I can also see that I would in my routine practice I would compare with the subsequent sequence to see the this active extravasation area um, whether it is increasing in concentration or not. So this patient, I would immediately take up my phone and inform the emergency team and the surgical team and also the intervention radiology team. This patient urgently require embolization. I think that the DSA images are for the embolization of this.
Do you call it a page kidney just by radiological from a radiological
No,
point
no,
of view?
with the hypertension and the history also matter. If with the trauma case, yeah, I don't think it is a page kidney. Yeah, sorry, I would retract my statement.
What would you grade this tumor?
Time up, guys.
Okay,
Grade 4.
okay, thank you, thank you. So I'll stop sharing. Dave, you can take over.
Yeah, okay. Give
One
me
second.
one moment.
Yeah, you can leave the mouse, Shabib.
Yeah. So yeah, you can start. I'll put the timer on.
Provided frontal projection of abdomen and pelvis in a adult patient. Striking abnormality I can see is a multiple hyperdense calcific densities along the corresponding to the renal medulla on the left side kidney. These are renal medullary nephrocalcinosis. I would quickly see the rest. I think the renal shadow appears smaller on this side, possibly atrophic, or I would compare with the previous images if available, also ultrasound images, trying to see there are any obstructing hyperdense calculi within it in on the left side. I can't see any calcific densities in the pelvis or along the tract of the ureter. Uh, okay. So other than that, I'm trying to see rest of the areas. I can't appreciate any. I can see some soft tissue opacity in possibly in
Oh,
the
I'm
right,
sorry. Yeah. Yeah. Go ahead.
possibly in the right interpolar region of the kidney. Otherwise, the source shadow is normal. Rest of the bones and soft tissues is grossly normal. I'm trying to
Mhm.
see if there are any lytic areas in the bone to suggest a brown tumor. I can't see any. So this is medullary nephrocalcinosis. The commonest cause is medullary sponge kidney. Um, the other possibilities are hyperparathyroidism and renal tubular acidosis that's expected to see in the younger age group with hypernatremia, and hyperparathyroidism will have elevated hyperparathyroid hormone hypercalcemia. So I would check with the lab parameters to see that. I would compare with the previous images if available. I would inform this finding to the referring clinician. The urology team will further evaluate in the urology and endocrine MTT. Thank you.
Apart from lab parameters, would you look for anything in the imaging itself that can give you a clue about the etiology?
Yeah, in renal, the medullary sponge kidney, usually I would check with the IVP images if available. IVP images will show a paintbrush appearance in the uh, uh, post contrast images. Other than that, I can also check if there are any other associated um, brown tumors and yeah, associated any features of hyperparathyroid such as clavicular erosion, all those things.
Okay, so in this case, what do you think is your most probable diagnosis?
Medullary sponge kidney. Yeah.
And do you know what is the management? What's the next step?
Yeah. This is actually a conservative management. It's a benign condition. Yeah, and
Okay,
surgical management if the patient has any obstructive symptoms.
okay. Move on to the next one. So this is a teenager who's come with cough. What do you think?
Okay. Provided frontal projection radiograph of the teenager present with the cough. I can see a opacity, which is a round opacity, possibly consolidation involving the right mid zone. Uh, I can also appreciate there are uh, prominence of the right hilar structures with yeah, right hilar structures appear prominent. The vascular structures also prominent. Or I would correlate with if any previous images if available. Other than that, I can see some the lung fields appear hyper expand the over expanded. The bilateral claustrophrenic cardiophrenic angle, the apex is normal. I'm looking through the bones. Okay, the bones appear grossly normal. In my routine practice, I would see it in a little magnified. Uh, I would see the little magnify and see the this right
Okay,
middle zone.
we can't help you there, but what are you looking for when you magnify this?
To see the outlying bone, yeah, outlying bone to see is there any. Uh, I,
The bone was normal.
okay. So to conclude, this is right middle lobe consolidation with I can see some irregular margins uh, along. I can appreciate some irregular margin along this areas of consolidation. Okay, I
What
would
if I were to told you
consider.
that this patient is known to the hospital and has come in previously with similar episodes?
Okay, so in that case, I would think of a um, mucus impaction possibility with a prominent bronchi. However, I can't appreciate any similar finding on the left side. Okay. Other than that, I can't see any. Yeah, I can't appreciate any obvious abnormality. Mm, I will in my routine practice I would compare if any compare with the previous images. I would inform this finding to the referring clinician, discuss the case in the respiratory MTT. I would recommend a follow-up scan also. Like I would recommend a further evaluation with a CT thorax.
So to conclude, what do you think is this is the infective process, or what is the conclusion?
So one possibility is an infection. Other possibility will be a mucous impaction. If the patient is a
So
non-case of cystic fibrosis,
if
I would check with the sweat
yes,
chloride levels. Yeah.
yeah, what did you say? Can you repeat that last sentence?
Yeah. If the patient is a non-case of cystic fibrosis, I would check with the sweat chloride levels. I would also compare if, with the previous images. Then other possibility will be a tuberculosis, less likely. Yeah.
If
I
I were
would
to tell you
recommend a
that
further evaluation.
if
Yeah.
I were to tell you
Sorry.
that the patient is a known case of cystic fibrosis,
Yeah.
then what do you think?
Yeah. In that case, I would think of a dilated bronchus with a bronchus, a mucous impaction first possibility.
Okay.
And there are other similar areas noted in the right lower zone as well. So,
Okay. So
yeah.
this patient, you find out after a call with the physician, is also presenting with abdominal distension and vomiting. So I'm giving you the CT for the same patient. You can see, ask for control and scroll.
Okay. Provided axial sections, post-contrast axial sections of abdomen and pelvis in the same patient with abdomen present with abdominal distension. Okay. I'm going through the images from top to bottom. Yeah, I'm coming back to the area. I can see that the pancreas is completely replaced by fatty tissue. It's in due to the it's a non-case of cystic fibrosis. Yeah, it's other than that, I can see there are dilated bowel loops. Dilated bowel loops involving the both small bowel loops, and I'm trying to see the large bowel loops. Okay, large bowel loops also appear distended in the box. Yeah, large bowel loops also appear distended with the uh, fecal matter, uh, distended with the fecal matter. So there are dilated small bowel loops, large bowel loops. In a non-case of cystic fibrosis, I would think of uh, distal in um, ileus, distal intestinal obstruction. Uh, make, s- Usually it involves the small bowel loops. You can also see the large bowel loops are also distended with fecal matter. Yeah. So other than that, I'm trying to see if there are any other abnormalities. These are due to the poor clearance of the secretions. Yeah, so I would check with the again. I would check with the sweat chloride levels. I would inform this finding to the referring clinician. Discuss the case in the surgical MTT. Uh, this is usually not sure about the management. Sorry.
As with okay, we'll go to that later. Let go of the mouse. I will show you the next case.
Yeah.
Yeah. Here you go.
Provided frontal position radiograph abdomen and pelvis in adult patient. Uh, Striking abnormality I can see is opacity, a calcific opacity just into the right sacroiliac joint, overlying the right sacroiliac joint. Other than that, I can also appreciate surgical staples in the pelvis on either side. With some soft tissues are also noted on either side of the pelvis. Looking through the rest of the areas, yeah.
Are you
I
sure you
can't.
would describe that structure as a calcification, the one that's overlying the right SIJ?
No, I don't think it's look like a button. Look like uh, foreign body possibly.
Mm-hmm.
Yeah, possible foreign bodies like button battery or something, because I can see some lucency surrounding the opacity.
Okay.
Okay. So this patient has undergone previous surgery, or it could be multiple foreign bodies as well. But this look like not it's look like outside the bowel loops. So this and bilaterally symmetrical. So it's possibly prior surgery related. So if I'm trying to see through there are any signs of pneumoperitoneum or dilated bowel loops. Not sure. I am not able to see any pneumoperitoneum or dilated bowel loops. However, in my routine practice, I would check the erect chest X-ray to better
I cannot give
characterize.
you erect chest X-ray, but I can give you the frontal view of the entire abdomen if you want.
Okay. Yeah. So provided abdominal X-ray of the same patient in more superior aspect. I can't see any air under diaphragm. There are dilated bowel loops. This is possibly dilated stomach and yeah, dilated large bowel loops also I can appreciate. There are some associated wall thickening, uh, associated wall thickening of the large bowel loop. So rest of the areas is norm. Other than I can also appreciate hyperdensities in the bilateral on both sides of the vertebra in the lower lumbar vertebra, sorry, upper lumbar vertebra D12, L1, L2 level. Either then I can also appreciate a radio opaque structure in the paravertebral location, possibly IVC filter. So, okay. So these are like post vertebroplasty, uh, possibly post vertebroplasty and IVC filter in situ, and this is possibly a migrated vertebroplasty material. The cement material must probably migrated, yeah, which is causing some bowel dilatation and secondary colitis.
Okay. So what will you
Yeah.
do?
I would inform this finding immediately to the surgical team, the referring clinician. I would further recommend a CCD abdomen for further evaluation. Thank you.
Okay. Next one. You, if you ask for control, you'll get it. Yeah.
Provided axial section MR images of brain. I will go from top to bottom of the images. I can, in a first glance, I can see there is the flare hyperintensity, the T2 T2 hyperintensity involving the right mastoid cells. Other than that, I'm trying to see through the brain parenchyma. Once again, I will go through my checklist. The brain parenchyma, other than that, no appear normal to me, except of the prominent sulcal spaces and ventricular prominence. Okay, I will check again to the paranasal sinuses, the orbit. I'm not able to appreciate any the findings. So if the patient has any features of, yeah, I can see this is extending up to the petrous apex. So if the patient has any
So yeah, the patient presented with headache.
headache, okay. I'm trying to see through the flow voids of the venous sinus. I can see there is loss of flow void involving the right transverse sinus and sigmoid sinus, possibly extending up to the internal jugular vein.
Your time is up. Your time is up.
Yeah, okay.
Can you please let go of the mouse? Yeah.
Sure.
Yeah. Okay. So we'll just quickly go through all the cases, and then Nikhil, I'll hand over to you after we go through the cases. Is that okay?
Yeah, sure. Yeah, go ahead.
Yeah, okay. So this was the first one. Well done. This was a case of medullary nephrocalcinosis, and again, I mean, I repeat this with everyone. It looks like you knew what the diagnosis was, right?
Yeah.
You didn't really you weren't that confused about it, but you still took almost 3.5 minutes to get through this case, which is a reason why in total you managed to see 4 cases, but you would have been able to give more time to the brain or see an additional case. Like the first case is usually an easy one. I'm not saying it has to be, but it's usually is. And if you are confident about the diagnosis, don't spend a lot of time thinking about it. If you know it, talk about it and quickly move on to the next case. So in this, you got a nice 7.5. Well done. The second one, so remember the history I gave you that was specifically, suggestive, that I said this is a teenager who has come with cough. So whenever you, again, I admit that this is not exactly a very typical, cystic fibrosis X-ray, but whenever I'm giving you an X-ray of a teenager, you the onus is on you to ask me for history or for previous records, and if the patient is known to the hospital, which you did, but you took your time to get to that point, right? So you wasted some time in the middle. But again, since you got the diagnosis, you were infective, you went with infective. This was a 6, and then with the second modality, this was I would have given you a 6.5 or a 7 with this because you got all the findings. But as with any intestinal obstruction, you have to mention that this is an emergency and I am going to quickly inform the surgery team. Just remember that these are very important things. You have to almost perform the necessary things. You got the radiological bit right, the imaging bit, but you have to do the next part as well. If you forget an essential step in the management, then it counts as a negative point, right? So it doesn't matter what you're saying. Stop right there, mention that it's an emergency, you're going to do XYZ, and then come back and move on with the rest of the imaging. Okay, just make that a priority. So this is where it got a bit tricky. I know this is kind of an overwhelming film because there are so many things going on. You did not see the IVC filter in the first radiograph. You mentioned eclipse, and this structure that took confused you a little bit. It's actually a capsule endoscopy. That's how they look on radiographs. Just it's okay if you haven't seen one before. So, but now that you have, make sure that you know what it looks like. And the other thing is, even when you saw this, so in this case, these are distractors. The vertebroplasty and the IVC filter are just there, and they're distracting you from what is actually a case of Crohn's disease with cholecystectomy clips, multiple previous surgeries, and this patient had adhesion, intestinal obstruction. I know the obstruction is not that visible, but given the history of multiple surgeries and a capsule endoscopy, you have to piece all these hints together and consider something that is a GI disease, and inflammatory bowel disease will fit the picture here. So you have to at least explore that possibility. Okay.
Yeah.
As for this one, you could have asked for more sequences, but I'm happy because you found everything. You found this, and that has led to this, which is better visualized on the T1, actually, the thrombus you can see here. So this is a case of dural venous thrombosis secondary to maxillary sinusitis. This doesn't really add a lot, but the Fiesta will show you you can see the thrombus slightly better here, and you can see the mastoiditis as well. So yeah, this was, if you had more time, you could have scored higher, but this was a 6 for you. Well done. Overall, you're doing well. The one thing that I would like to point out as a general bit of advice is the examiners often look for an opportunity to help you along, right? So they might interrupt you, or you should make it easy for them to interrupt you. Like give some space between some of the sentences, especially if you think you need some help, and give them the opportunity to help you. So if they are interrupting you, make sure you always let them, because what they're saying will inevitably help you. It will never be something that takes you away from the diagnosis. So your speed in general is good. Just give a slight and a half a second more gap in between sentences, so that they might, if they want to, they might come in and put in a sentence to help you along. Okay.
Thank you.
All right. All the best. Nikhil, I'm stopping my screen share.
Sure. Yeah. Shabib, I think you're a very strong candidate to me personally. There are a few things that I also felt your speed could have been a little lesser. I think you're racing a bit. And the fact that when I did try to ask you a couple of questions in between, you kind of did not notice that I was trying to ask you a question and you were in a pace to finish up the case, which is a good thing. But I feel like they've said maybe a step down could be done.
Yeah, my concern is like as long as examiners prompt us, our scores will come down. No, that's I don't know. It's like that's what I understand about it.
No,
And
no. If the examiners are helping you, then the score comes down. But don't worry about the prompting, because as I was saying in the previous session as well, we were surprised by how much of a conversation this is. Think of it as a discussion. Once you've seen the case, the examiner will ask you a lot of questions. So they're not necessarily prompts that are helping you. They're asking you questions to further explore what you know about it. So don't worry about, don't do that.
Correct, correct.
yeah.
Because yeah, at the first room that I did during my exam, I just happened to see only 4 cases with one examiner, and with the other examiner, I happened to see only 3 or 4 cases. I thought I had really done lesser case, but then I ended up getting a 7. So I feel, but then that was more of a discussion case, that room, and then the fact that the speed has to be very much regulated. It's more of a discussion. It's not a race where you need to finish it off and then end it up and then give them a chance. It's more of like you say something and they want to ask you more about it. So I think, like they've said, put a little of pause in between so that it does not feel very robotic when you're talking about a case. Okay, number one. Number two, I think you about referring emergency things. Whenever you see something emergency, please do refer it then and there. So I think you remembered in the first few cases, but then when it came to the subsequent cases, it you kind of lost it. So, which is perfectly fine. I still feel that your preparation level is on the mark. You are picking up the findings very well. So I think I would definitely give you a 6.5, 7 for all the cases that they've did. Now, coming back to my cases, I think, yeah, let's do that. So, I think this was the first case. Sorry, this was the last case I showed you. Um, so, in this DSA images, I give you a history that this patient had a history of trauma, and you picked up very well about the contrast extravasation. So, a good approach would be to trace along the margins. Okay, so if you go along the margins, if you look here at the lower pole, there is a
Yeah,
contrast
yeah,
leak going right through.
yeah,
Right,
yeah,
I would not penalize you down here because you kept your composure, uh, understanding the fact that this could be a very tricky case. But I would have definitely been happier if you had traced along the margins and picked up this leak. Okay,
yeah,
and subsequently I could have shown you a post embolization picture which had shown the embolization at that level, right? But
yeah,
when it came to CT, you picked up all the findings, and I would also um, recommend that do not overcall things. Do not commit something like page on the spot. Just stick to your findings, and then once you summarize it, in this case, if you're summarizing, you could say that there is an evidence of trauma to the kidney with active contrast leak. I would categorize this as an AAST grade 4. So that kind of gives them a picture that you are aware about the grading system. Okay.
mm,
Do not wait for me to prompt you to tell me what grade it is and what management you would go ahead with, right? So
mm,
otherwise, I think you did this case well. I would pass you on this case. I think the next case that I showed you was this avulsion fracture. Please revise all the attachments. I think initially you were a bit confused about what muscle it was. In my routine, like, so if you were pretty confident, you could directly say that since this is an attachment, proximal attachment for rectus femoris, I would be concerned for a tear or an avulsion tear of the rectus femoris, right? That would come across as a better, confident answer. Right? I wouldn't need to prompt you at that level. Right? So otherwise, you did this case well. This case also, another thing that I noticed with you is you know the findings and you pick it up, but then you're dragging the case too much. Like Dave said, you could have saved a lot of time on multiple cases that we both showed, and you could have added up 1 or 2 cases more. Otherwise, I think just bring down your description part. You kept describing, and in real exam, examiners are not going to interrupt you. The more you talk, they'll let you keep talking. They are not going to say, okay, this is done, let's go to the next. No. So it's better, I think, like the first candidate did, just say whatever you have to say and say thank you so that they know, okay, the candidate has ended. Now I can question him, right? So this was a case of vesico-uractal diverticulum. The fact that the diverticulum is extending anteriorly, okay, should make you think of it. And I'm glad that you did pick up that differential in the diagnosis. And apart from that, you see vesico-ureteric reflex, and you were also spot on that you should be worried about a urachal adenocarcinoma in long-standing cases. Okay. Then I think I showed you this case. You were very spot on. When I gave you the history, your thought process quickly went along the lines of a cesarean scar site pregnancy. The treatment is ultrasound guided methotrexate injection. Something which is contraindicated is dilatation and curettage. Okay, always remember that. You should not mention DNC for such cases. Always stick with ultrasound guided methotrexate, which is more of a radiological procedure. So always remember managements which are radiological. Okay. So otherwise, I think you did pretty fair. I would give you an overall of a 6.5, even a 7. I think I'm done with it. Dave, do you have anything else to add to this?
No, not really. I've said for your cases, yeah, I agree. I mean, you were trying to ask him a few questions, which he didn't give you enough time to, so that I already mentioned that in my feedback.
Yep.
But other than that, yeah, I think you're ready, you're prepared. Just make sure that you perform adequately. That if there is an emergency, make sure you stop and really emphasize on it. Like do a bit of voice modulation. Don't you have a very flat tone, which is good when you're describing something, but you have to change it a bit and just be a bit more animated that this is an emergency and I would be worried about it, and I'll pick up the phone and just make sure that examiner knows that you know that it's an emergency, right? It's a bit of a performance, unfortunately, but you got to do that so that they don't feel that you're not attaching enough importance to a particular finding.
Yeah.
Yep. Do you have any questions, Shabib or Smita, regarding any of the cases that we've shown yet?
That misplaced stent case, was there any opacity in the left kidney? I'm not sure.
The one with which I showed, Dr. Smita, the DJ stent?
Yeah.
Yeah, no, there was nothing else. It was just a DJ stent that is displaced down into the urethra. Okay.
Okay, thank you.
Yeah.
Thank you, both of you.
So thank you
Thank you.
everybody
Thank you so
for
much.
sticking around with us. Please, I would emphasize all the September candidates, please volunteer and participate in this so that you get a feel of how the real exam is. Because the patterns are changing. So it's very important that you get exposed to such kind of vivas, and hoping to see more of you candidates in the coming sessions. Okay. So yeah.
As for I think there are a couple of questions here. Would you take care of some of your questions? I'm trying to answer most of mine.
Yeah, right. So Varsha has asked, in urachal diverticulum case, the right ureter is deviated and short. Is it drooping kidney? Unfortunately, I did not show you the entire pelvic radiograph from the level of the kidney. So I think it's better in such cases, do not overcall unless they have given you an entire sequence, Dr. Varsha. So I would just stick with some things which I can clearly see. Yeah. Okay. Sasha, I think I have answered your case. It was a case of vesico-urachal diverticulum. Yeah.
As for the question about the rib lesion, well, it kind of depends. So if you're thinking it's a fibrous dysplasia, or if you think that you need to characterize the internal matrix characteristics, then CT is the one which we commonly perform. However, if many times we often end up doing both, if you want to, because MRI has superior soft tissue resolution. So if you want to look at the chest wall involvement, the soft tissue involvement, then the MRI is indicated. If there's a concern for a very aggressive sarcoma of some sort, like osteochondroma transforming to a sarcoma, or a very aggressive, I don't know, Askin tumor or that kind of aggressive pathology, then we do MRIs right away. And then we end up doing a CT anyway if you're doing a CT guided biopsy, right? So the bone biopsy in a sarcoma center. So it depends on the kind of pathology. Very often we end up doing both.
Yeah, regarding the management for medullary nephrocalcinosis, it's based on the etiology, right? So if it's
Yeah.
a hypoparathyroidism, you trace along the lines of that and treat. So it's very
If there's an underlying cause, yeah, you just treat that. But if it's the sporadic mutation that leads to it, like this case, medullary nephrocalcinosis, there's nothing much to be done. You send the patient home, conservative management, that's it.
Yeah. Okay. So I think we are done with the doubts. Otherwise, feel free to
Yeah.
text in the Telegram group as well. And until then, I think we'll meet. So the next session will be probably this coming Thursday on 15th of August. And
Yeah. We'll put up the notice
I
quickly.
think there are a few candidates who are quite not available. So next time, what we are planning to do is whoever is available, they can right away text in the Telegram, and we'll pull them up for the next session. Okay. Thank you so
Yeah.
much.
What time do you think will we do it on Thursday? We can just tell them so that they know here around this time, same time.
Around this time, yeah. I think the earlier the better for everybody. So around 6 o'clock, is that okay for everybody to join in?
We'll have the discussion on Telegram then. Okay, chalo.
Thank you so much, everybody. Yeah, bye.
All right.